Hello. This module will evaluate the utility of point-of-care ultrasound for pulmonary, specifically focusing on the evaluation for pneumothorax. The utility of point-of-care ultrasound for thoracic imaging has been demonstrated. In fact, the use of point-of-care ultrasound to identify pleural infusion, consolidation, and pneumothoraces has actually been demonstrated to be superior with the utility of point-of-care ultrasound versus standard chest X-ray imaging. So again, indications for the utility of lung ultrasound has been demonstrated for detection of a pneumothorax, detection of pleural fluid, and for the detection of pulmonary parenchymal disease or airspace disease. This section will talk about the evaluation of point-of-care ultrasound for the detection of a pneumothorax. When it comes to the assessment of a pneumothorax via point-of-care ultrasound, what we're essentially doing is evaluating for the natural phenomenon of the visceral and parietal pleura sliding across each other in that pleural space. So traditionally, when the lung is getting appropriate aeration, you have your visceral and your parietal pleura able to slide across each other. And that changed because as the density in this space changes, it causes a differentiation in the echo reflectance as, again, the motion occurs, and you're able to detect that motion on ultrasound. So here, from that cartoon, this is an actual ultrasound image. We see rib here, and this motion pattern is, in fact, demonstrating that visceral pleura sliding across the parietal pleura. When a pneumothorax occurs, you now have an air interface between the visceral and parietal pleura. And so therefore, you will no longer see this motion pattern or this lung sliding phenomenon. So the absence of a lung sliding across the pleural line is an indication of being concerned for pneumothorax. I want to highlight this very important point that just because you have an absence of lung sliding, that does not necessarily mean you absolutely have a pneumothorax or that pneumothorax is clinically significant. But the concern of having absence of lung sliding should you make you aware or put on your radar the possibility of a pneumothorax. So you see in this cartoon here, we have air separating the visceral and parietal pleura. How that translates onto ultrasound is now we still have that hyperechoic line, but we see with the respiratory motion, you can see change of the intercostal muscles here. You do not see that sliding fashion occurring at this pleural line. So the absence of lung sliding or that sliding of the visceral and parietal pleura across each other is a concern for the possibility of a pneumothorax. How do we obtain this imaging? Well, we want to have our ultrasound plane in between rib spaces. So we place the probe vertically with the indicator at the 12 o'clock position, and we want to identify the most anterior aspects of the patient's chest. Traditionally, when it comes to the anterior pulmonary exam, we look at 6 regions, 3 on each side, that should be systematically examined for all aspects of the lung fields. So here we'll show you the initial starting point. We traditionally start off with the indicator again here aiming at the 12 o'clock position. You see how we have set the footprint of the probe in between rib spaces. And ideally, we'd like to start off with the most anterior aspect usually being across the midclavicular line for the proximal 1/3 of the chest wall, and moving further lateral into the anterior axillary line as you go further down the chest wall cavity. And following this pattern will allow you to insonate most anterior aspects of the patient's lung fields. It's very important to identify 2 specific strategies when it comes to the evaluation for lung sliding. One, we're looking for comet tails, which are these linear reverberation artifacts that occur at the pleural line and are caused by the bouncing back and forth between the dense fibrous tissue of the visceral and parietal pleura. So when these 2 pleura are together and sliding across each other, they will cause these reverberation artifacts called comet tails. And this shimmering pattern will demonstrate on the next video clip. Lung sliding again is that actual motion that we're looking for of the visceral pleura sliding across the parietal pleura. Very important that just by having the absence of lung sliding, that does not necessarily mean that you have a pneumothorax, you can have main stem intubation, you can have another situation where any situation where you would have inappropriate ventilation to that given lung field could potentially cause the absence of lung sliding. However, the detection of what's called the lung point is actually a very pathognomonic sign for a pneumothorax. And what this is being scanning in these fields here to identify the location of where you see lung sliding and you identify where the lung sliding stops. And that area is called the lung point, where you see in the same ultrasound image an area of lung sliding followed by an area of absence of lung sliding. That point is called the lung point, and that is much more recognized as a pathognomonic sign for a pneumothorax. That's why it is very important to follow this traditional imaging technique of scanning through multiple intercostal spaces on both sides to detect a full appreciation for the patient's lung pathology, with the key caveat of realizing that the pneumothorax will occur at the highest point in the patient's chest in the supine position. So in the supine position, we're looking at the most anterior aspects of the patient's chest. If the patient was sitting upright, again, you would look at the most superior or anterior aspect of the patient's chest, depending on their position. One can use M-mode imaging to get a greater degree of detection of this phenomenon of lung sliding. So again, just to review from the physics section, M-mode imaging is essentially a dagger of ultrasound over time. So you're able to see just a slice, perhaps of this picture right here, of that particular path of ultrasound beam over time. And so again, M-mode is a singular line of ultrasound imaging displayed over time. What you're able to see with the use of M-mode imaging is the identification of the seashore sign versus the barcode sign. So the seashore sign is the idea of showing the area where you have no motion from the chest wall, and then you identify pleural motion when you have appropriate lung sliding. So you have your sand and sea picture here, or the seashore sign. This again indicates, this motion artifact indicates that you have appropriate pleural sliding. When you have absence of this pleural sliding, that would present itself as the barcode sign. So when the chest wall imaging of matches the pleural imaging, indicating that there's a barcode-like pattern throughout the ultrasound M-mode image, that's a concern that you have absence of lung sliding. Again, to go back to the concept of the lung point, here you can see this picture here where we see on the right side of the image appropriate lung sliding, but we see here on the left that there's actually an area of no or absence of lung sliding. And the detection of this area here, where you have no lung sliding followed by an area with lung sliding, is the lung point. And this identification, again, no lung sliding here, followed by an area where you are able to identify lung sliding, shows that we have instillated this interface of the air separating the visceral and parietal pleura. And when you have that ability of detecting the lung point sign by doing the systematic ultrasound examination, you can more definitively appreciate the fact that the patient does have a pneumothorax. M-mode imaging as well can help identify this. Again, I'd like to highlight and emphasize that it's important to note that the lack of lung sliding alone is not sufficient to make a diagnosis of a pneumothorax. This absence of lung sliding can be secondary to apnea, bronchial intubations, or bronchial obstructions, pleural adhesions, and large infiltrates. But the absence of lung sliding should warrant further evaluation to demonstrate the possibility of looking for mechanisms of what's occurring. Additionally, the concept of looking for avenues in which the lung ultrasound is actually penetrating deeper into the lung parenchyma, or looking for the presence of beadlines, is another way of looking for appreciation of a pneumothorax. So here again, just to show again, indicator vertically in between ribs, looking for this appropriate sliding here phenomenon here. So now I will demonstrate on our mannequin the identification of lung sliding. Okay, so we're going to demo the pulmonary exam, specifically looking at the evaluation for a pneumothorax. as the picture in the last slide demonstrated, we want to start off in the mid-clavicular line, approximately the proximal 1/3 of the chest wall, and then move laterally such that you are on the anterior axillary line as you go below the 2/3 below the nipple line. To do that, first we'll remember we have an ultrasound plane to be vertical across rib spaces, such as that the ultrasound plane is in this fashion. We're going to be aiming initially in between ribs, and we're looking for that phenomenon of lung sliding. So you can see here in this picture the concept of lung sliding. You see this slowly movement of the lung pleura shown at the top hyperechoic line. I'll decrease the depth here to kind of further extenuate this. And we're just looking for, in fact, verification of this movement of this pleural line in between the ribs. So just to try to show the relationship, there's a rib, and there's another rib. Our ultrasound plane is cut in between those two rib spaces, and we're looking for that sliding phenomenon or the motion appearance across the lung pleura. We're going to continue that in all 6 areas of the anterior ultrasound examination to evaluate for pneumothorax. And again, as the PowerPoint discussed, we can look at the use of M mode to get a higher fidelity image quality to evaluate for this phenomenon of lung sliding.